Hello, everyone, and welcome to today's webinar, Treatment Modalities for People with Kidney Disease. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You have joined the presentation listening using your computer speaker system by default. If you prefer to join over the telephone, select the audio next to the mute or unmute icon on the bottom of the Zoom screen. Select Leave Computer Audio and then select Phone Call and follow the dial-in call in. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions anytime during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Today's webinar is being recorded and you'll receive a follow-up email within 24 to 48 hours with a link to view the recording. In the early stages of chronic kidney disease, lifestyle changes such as getting more exercise, stopping smoking, and cutting down on sodium, managing other medical conditions, and taking a few medications may be all the treatment needed to slow down the damage to your kidneys. People often go for many years or all their life without needing other forms of treatment. And the kidney function does continue to decline, they may start developing symptoms of kidney disease. Each person is different, but most people will start to develop symptoms when the kidney disease becomes severe. At that time, people will need to discuss additional treatment options with their healthcare team. There's a lot to learn and a lot to understand for people living with kidney disease. If their kidneys fail, there are several different treatment options, including non-dialysis supportive care, conservative care, transplantation, or different forms of dialysis to consider. This webinar topic is intended to help inform people who are facing a number of treatment options to discuss potential treatment options with their healthcare team early on. That way, they have time to prepare, to plan, and ensure that they are making the treatment choice that's best for their lifestyle, health, and personal circumstances. The Kidney Foundation of Canada would like to thank our sponsors providing unrestricted educational grants to make this webinar possible. AstraZeneca, Horizon, Otsuka, Sanofi Genzyme. The Kidney Foundation of Canada is thrilled to have our speakers for today's webinar, Dr. Joanne Koppel and Peggy Gillespie, and Lydia Lauder, the Director of Programs and Public Relations. Dr. Joanne Koppel completed undergraduate and postgraduate medical training in Saskatoon. Nephrology fellowship was undertaken at the University of Toronto. She returned to Saskatoon in July 1989 to begin private practice, nephrology associated with the College of Medicine, University of Saskatchewan. She is currently Clinical Professor of Medicine, Provincial Medical Lead for Kidney Health, and Medical Director of Chronic Kidney Disease Program, Saskatoon, with the Saskatchewan Health Authority. She is the Chair of the National Programs and Public Policy Committee and is the Saskatchewan Branch Medical Advisor for the Kidney Foundation of Canada. Dr. Koppel is also the Co-Chair of the Knowledge Translation Committee for the CanSolve, CKD, and Network. Peggy Gillespie is 57 years old. She is a daughter, granddaughter, sister, niece, student, wife, mother, aunt, daughter-in-law, sister-in-law, friend, employee, and oh yes, a nephrology patient. On October 6, 1979, she was diagnosed with glomerulonephritis, likely due to a viral infection, and started on hemodialysis. Over the past 40 years, she has had experience living with the home hemodialysis, in-center hemodialysis, self-care hemodialysis, continuous ambulatory peritoneal dialysis, automated peritoneal dialysis, and has had 2 successful kidney transplantations. She has been back doing hemodialysis for 17 years now, and for the last 4 years has chosen to do dialysis treatment at home. In today's webinar, Dr. Koppel will provide an overview of the various treatment options available for patients with kidney failure and will lead them a discussion with Peggy Gillespie about her treatment journey. And now, over to you, Dr. Koppel.
Thank you very much. Thank you very much, Tracy, for that introduction. This first slide here shows the stages of chronic kidney disease. I'm sure that some of you have been told that you may have stage 3B kidney disease, and you go to say to yourself, what does that really mean? Well, there are two ways of figuring out what CKD stage you are at. The first is a blood test to determine your GFR category or percent of kidney function. The second is a urine test to determine how much protein you have in the urine. So if you have stage 3B kidney disease, you have moderately to severely decreased kidney function, and depending upon the protein in the urine will depend upon whether you're in these red boxes or in the orange boxes. The red boxes signify that you have a very high risk of progressing to end-stage kidney disease. But having said that, every individual person is different, and everyone responds to treatment differently. And so those are the types of things that you need to talk about with your healthcare practitioner. So sorry about this. There we go. So the keys to kidney health, and I'm bringing this up because I think at all stages of our kidney journey, we should try to maintain as much kidney health as possible to help our kidneys work as long as possible. So some of those things include lifestyle changes, some exercise, even if you can only start out with 5 minutes every day, walking or doing some chair exercises, that will really help with your kidneys. If you can lose a little bit of weight, if you're smoking, to stop smoking, if you're eating a lot of salt, to decrease the salt, and particularly decreasing processed foods, because that's where most salt actually comes from. And if you are drinking alcohol, to drink in moderation. The other aspects of kidney health is to maintain a healthy blood pressure. And everyone's blood pressure target is different. So you need to ask your healthcare provider what a healthy blood pressure is for you. If you are diabetic, you should check your blood sugars and try to keep them within, again, blood sugar levels that are customized for you, because people are different. And all the medications that you take, including medications that are prescribed and medications that you may buy over the counter or in the health food store, should always be reviewed to ensure that they are not potential toxic to your kidneys. And so some of the medications that you can buy over the counter that do decrease kidney function are anti-inflammatory medications that are called NSAIDs. And for instance, it's like Advil, ibuprofen, Aleve, etc. And certainly if people are shooting up drugs, that will decrease your kidney function. And so if possible, to get help with addictions counseling. So based upon that stage of chronic kidney disease, when should you begin discussing treatment options with your healthcare team? For sure, you should start treatment discussion if you're at stage 3B or stage 4, or certainly by stage 5 kidney disease, because ideally you would want to make sure that you have a decision made about what you want to do if your kidneys continue to fail. And that decision should certainly be made by stage 5, and if possible, made by stage 4. So the sooner that you start talking to your healthcare team about what you would want to do if your kidneys continue to decrease in function, the better it will be for you, because knowledge truly is power. So you know when to begin the discussion, but sometimes people are afraid to ask questions. And so the following slide is some questions that you can ask your healthcare team. So these are sort of how to begin discussing treatment options with your nephrologist or kidney doctor, or with the kidney health nurse in your kidney clinic. So some of the questions that you might want to ask are, what signs and symptoms should I look for as my kidney function decreases? What can I do to keep my kidneys working for as long as possible? If my kidneys continue to decrease, what treatments may be right for me, given that you know my underlying health condition? What is my prognosis? What am I looking for in the future? When do you think I will need to start dialysis? Or when do you think I should have a kidney transplant? And can you explain to me the different kinds of dialysis? Some of the questions may be, I have lots of health conditions. I have heart disease, I have lung disease, and now my kidneys are not working. So what if I don't want dialysis? What will happen? Can you tell me? Am I a candidate for a kidney transplant? And if so, really, what do I need to do? How do I get referred to the transplant team? If I go on dialysis, can I still travel? Can I still go to work or go to school while I'm on dialysis? Those are just some of the questions that you might want to take when you're starting to discuss treatment options as your kidney function starts to decrease. There may be other questions that you want to add to this list as well. So when it comes to choosing a treatment option or discussing about your treatment options, there are 4 big options for treatment when your kidneys are not working as well as they should. And these are in no particular order. The first, however, is conservative kidney management, or sometimes we abbreviate things to CKM. Second is peritoneal dialysis, or PD. The third is hemodialysis, or HD. And the fourth is kidney transplant, which we usually abbreviate to TX, but we always say kidney transplant. So we're going to go through each of these 4 options in a bit more detail. So the first is conservative kidney management. So this really is the option of choosing not to start dialysis, because everyone's situation is different. Everyone's health status is different. Everyone's values and preferences are different. And for some people, quality of life is much more important than how long they will live. So conservative kidney management involves interdisciplinary care. So there's still a team of people that take care of people who have kidney failure, but have chosen not to start dialysis. And those team members include the dietitian, so we go over your diet. We give you management for low blood or anemia, and that may include an injection called erythropoietin. We still want to control your blood pressure, although maybe the targets are not as narrow or as rigid. We would like to control any symptoms that you may have due to kidney failures, for instance, like itch or restless legs or leg cramps. And certainly a big part of conservative kidney management is providing psychological and spiritual care, not only for the person who has kidney failure, but also for their family and caregivers. This graph that is on your screen right now is a trajectory of illness. This comes from a very excellent nephrologist called Jean Hawley, who works in the United States. And this just tells you the trajectory of a person's illness. So if you have colon cancer, for instance, you have chemotherapy, maybe some radiation, but if the colon cancer then spreads to your other organs, you have a rather rapid deterioration until you pass away. If you decide that you're going to have conservative kidney management and choose not to start dialysis, then this red line here shows that your kidney function may continue at a very low level, but continue on for some time. And then there comes a point when the kidney function does decrease a little bit more, and then you have a more rapid decline until you pass away. During this time where your kidney function is slowly sort of declining, most people have actually very few symptoms. And if people choose not to start dialysis and choose conservative kidney management, their manner of their death is not painful. Basically, a person falls asleep and does not wake up. If a person has pain when they choose not to start dialysis, it's because of their other underlying illnesses, like for instance, cancer. If people decide to go on dialysis, so then this blue line here where you have these dips, and these dips. So these dips are if a person has heart failure or has COPD, which is chronic obstructive pulmonary disease, or the old word was emphysema, and or if you have end-stage renal disease and start dialysis. So every now and then you will have a dip in your health status because something's happened and your kidney function decreased, and you have this gradual decline over years until again you pass away. So the time from when you choose not to start dialysis to the time where you have started dialysis, sometimes this time here may be actually very short. It may be a matter of weeks, or it may be a matter of years. Every person's situation is different. And so it is very important, if you are not really clear about what you would like to do, should your kidneys continue to decline in function, is you do need to ask those questions of your nephrologist or kidney doctor or the CKD clinic staff, is really, what is my prognosis? What do you think is going to happen to me if my kidney function continues to decrease? How long do you think I will live? Those are important questions to think about. Second option then is that big dialysis bucket. And within that dialysis bucket, you have two options for dialysis. One is peritoneal dialysis, and the second is hemodialysis, and we'll go over both of them in the next few slides. But basically, peritoneal dialysis uses the peritoneum, and the peritoneum is the very thin membrane that lines your intestines and lines the inside of your belly. It's like saran wrap. And there are a ton of small little blood vessels in that saran wrap lining of your belly that actually does the job of filtering out the toxins and waste products into this special fluid that you put into your belly. Peritoneal dialysis is done every day, and it's done at home. Hemodialysis, or blood dialysis, uses a machine to clean the blood. The machine may be big, the machine may be small. Typically, hemodialysis is 3 times per week for about 4 hours. That's typical, but again, everyone is different. Hemodialysis can be done in your home. So home hemodialysis, where you learn how to do the hemodialysis yourself, and you'll hear about that from Peggy. Hemodialysis can be done in a hospital unit. Hemodialysis can be done in a satellite unit, or hemodialysis can be done in a freestanding clinic. A lot of hemodialysis in the United States, for instance, is done in a freestanding clinic. In Canada, a lot of hemodialysis is done either in a hospital, a satellite unit, or in your own home. So let's talk about peritoneal dialysis. So in this slide on my left-hand side, and I'm assuming on your left-hand side as well, this here is the abdomen, and this red line is that peritoneum. That's that thin membrane that acts like the filters of your kidney. So you have this catheter that is put into your abdomen. The catheter looks like this center box. There are many kinds of catheters. There are straight catheters, and then there are curled catheters. These catheters are inserted into the abdomen, usually with a local freezing or local anesthetic like the dentists use, and the catheter can be inserted at the bedside or in the x-ray department. But in some individuals, however, the catheter has to be inserted by a surgeon using a scope, so a laparoscopic insertion of the catheter. And the people that need to have a surgical implantation of the catheter are usually people who have had some operations on their abdomen before. So once you have that catheter in, you have this special solution called dianyl that is made up basically of sugar and a few other things that's put into your abdomen. It sits in your belly there for a couple of hours, and those little tiny blood vessels are filtering the toxins into that fluid, and then after a few hours, that fluid is then drained out into that drain bag, and then that drain bag is thrown down the toilet. And so this drain bag is kind of like the pee that you have right now. This here on your right-hand side is what a catheter can look like. You can see that there is an extension set on the catheter. So this extension set is changed by the peritoneal dialysis staff generally every 6 months, but the catheter can stay into your abdomen for years if there is no problems with the catheter function. So I've had a patient that I've taken care of for 18 years that's had the same catheter in place without an issue. So once you have that catheter in, the catheter site has to heal, and every program is a little bit different because every program puts the catheters in a little bit different, but generally the catheter has to heal for at least 2 to 4 weeks before you can be trained on peritoneal dialysis. And there are 2 types of peritoneal dialysis. The first type is called CAPD. That's really peritoneal dialysis exchanges by hand. So it's continuous, that's the C, all the time. A is ambulatory, means that you're walking around in between your dialysis exchanges. P, of course, is peritoneal, and D, of course, is dialysis, which is cleaning the blood. The other kind of peritoneal dialysis is peritoneal dialysis exchanges by machine, or CCPD or APD. And C means continuous dialysis. The second C is cycling. P, of course, is peritoneal, and D is dialysis. So CCPD uses a machine that's called a cycler to do the dialysis exchanges at night while you're sleeping. And sometimes CCPD is called automated PD or APD. So if we look then at what CAPD is, so this is it's called manual exchanges. So this is the bag that will be put into the belly. So in this picture, the person is draining the peritoneal fluid from her tummy. And then when this bag is full, then she will shut off the valve, and she'll open up a valve to put this fluid back into her belly. When that fluid is in her belly, she will disconnect from this, my finger is getting trigger happy here, guys. Oh dear. I apologize for this, people.
Dr. Capel, can I help?
Nope, I'm good. So once she has filled her belly with this fluid, she will disconnect herself from these 2 bags. She'll put a cap on the end of the catheter, and then she'll drain this bag into the toilet. And then this person will go about her day, go shopping, go do the housework, go to work, go to school, and then in about 4 or 5 hours, she will repeat the process again. So that's what's called CAPD. So generally, when you're doing CAPD, you are doing about 4 exchanges per day: at breakfast, at lunch, at supper, at bedtime. The whole exchange process to drain and fill usually takes about 30 minutes. So people tend to do it while they're, having their breakfast or having their lunch. I've had people who've been on CAPD who are from northern Saskatchewan, who go fishing, go on the trap line. This thing has an idea manner, so that's all. So CCPD now, or APD, automated peritoneal dialysis, uses this little machine called a cycler, and there are several kinds of cyclers on the market now. And so this here is the machine that you just simply have a picture of, and these bags on the top are being heated, and these bags are being drawn into this heater bag. And this person here is doing CCPD or APD while he's getting ready for bed, or or reading a book or whatever. So CCPD is generally done at night. So people hook themselves up before they go to bed, and they're generally on CCPD or APD for about 8 to 9 hours at night. Then they get up in the morning, they detach themselves from that machine, and they go about their day. And they don't do any exchanges during the day. So 2 types of peritoneal dialysis, CAPD and APD. So what are the benefits or the drawbacks of peritoneal dialysis? Well, some of the benefits of peritoneal dialysis, of course, is you do it at home. It's flexible, so you can fit it around your life. It's easy to take your therapy with you if you want to travel. So if you have that machine, that APD machine, there's a special suitcase. You can take it with you on the plane. You take it as your carry-on luggage, and the company ships those bags of fluids to wherever you're going, with certain caveats. They don't ship to countries that are at war or have a violent history. So you can travel with peritoneal dialysis. There's certainly, because you're doing this every day, there's less stress on your body. It's more like your native kidney function. Your diet is a little bit more liberal on peritoneal dialysis because, again, it's done every day. There's no needles involved except when you have to have a blood test. It actually preserves your own kidney function for a lot longer than hemodialysis or blood dialysis would. And you can do the therapy while you sleep and have the day to go about your business. But some of the drawbacks is that you have to have a catheter in your body, and some people don't like tubes hanging out of their body. Because you have that catheter in your abdomen, you have to be careful about bathing or going into a hot tub or swimming in a lake, because the exit site where that catheter comes out of your abdomen could become infected if you're sitting in a hot tub, because hot tubs are full of little germs. The exchanges need to be done every day, so it's not something you can do a couple of times a week. And there, of course, is some risk for infection because of that fluid in your belly, and that infection is called a peritonitis. Most of the time, that peritonitis can be easily treated with antibiotics that you put into that fluid. And some programs actually train you how to do that yourself. You do need storage space in your home for the boxes of fluid that come either if you're on the CAPD or the manual type of dialysis, or the boxes of fluid for the machine type of dialysis. And because that dialysis fluid has sugar in it, some people will gain some weight. So that's sort of an overview of the types of peritoneal dialysis: CAPD, which is manual peritoneal dialysis, or APD, which is automated or machine peritoneal dialysis. The other dialysis option is then hemodialysis. So hemodialysis means that you have to have a machine that actually pumps your blood out of your body through a special kidney called a dialyzer or an artificial kidney. And as the blood goes through that dialyzer or artificial kidney, toxins and waste products and extra fluid is removed, and then the clean blood is pumped back into the body. At any one time during that hemodialysis procedure, there is about 1 cup of blood outside of your body in the dialysis lines and in that artificial kidney or dialyzer. You have about 5 to 6 cups of blood in your body. And during a hemodialysis session, your total amount of blood is generally cleaned anywhere from 8 to 12 times, depending upon how long you're on the machine. So in order, though, for hemodialysis to be done, we have to have access to your blood circulation. And access to the blood circulation means one of 3 things: either an arteriovenous fistula, or AVF, which is the gold standard for hemodialysis. And what an arteriovenous fistula is, as a surgeon takes you to the operating room, and again, usually with local freezing, or sometimes you're put to sleep, they connect the artery in your wrist to the vein in your wrist. And you can see that in the cartoon figure on your right-hand side. And on your left-hand side, you will see that 2 needles are put into that large vein that grows after the fistula is put in. So the fistula must be done in the operating room. It usually takes 6 to 12 weeks to mature. What that means, it takes 6 to 12 weeks for the vein in your arm to get big enough so that we can put the needles in to do dialysis. So one of the needles takes blood out of the body and it goes through the artificial kidney and the blood is clean, and the clean blood then is put back into the body by that second needle. So the arteriovenous fistula is the gold standard for hemodialysis. Sometimes people don't have very good blood vessels. And so if we can't do a AVF, then the next option is an arteriovenous graft. And on your left-hand side, you see the plastic tube that's actually put under your skin and attaches the vein and the artery, usually in your elbow. So that will give us access to the arteriovenous fistula. So on your right-hand side, you see that white tube, so that's the arteriovenous graft. And again, you see, 2 needles are put into the arteriovenous graft, the same kind of needles that are put into the arteriovenous fistula or AVF. And again, 1 needle takes blood out of the body, goes through that artificial dialyzer, the blood is cleaned, and the the second needle takes the clean blood back to the body. So arteriovenous graft is our second preferred method of getting access to the blood system to do hemodialysis. Our least preferred method is a central venous catheter, or CVC, or sometimes people call it CVL, central venous line. And a central venous catheter is put into the big vein of your neck, so usually the internal jugular vein, either on your right-hand side or on your left-hand side. This central venous catheter can be put in by the nephrologist or by the X-ray doctor in the X-ray department. It is usually tunneled under the skin and then put into the jugular vein, either on the right or the left, as mentioned. The central venous catheter, once it's put in, can actually be used right away. So an arteriovenous fistula needs to have 6 to 12 weeks to get mature, to be ready for dialysis. An arteriovenous graft usually can be used within 2 weeks, but a central venous catheter can be used right away. So sometimes people will present with kidney failure that has happened all of a sudden, or it wasn't recognized, and they need to start dialysis immediately. So in that situation, we have to use a central venous catheter to clean the person's blood, improve the potassium, etc. So what are the benefits then of hemodialysis? So there are really 2 kinds of hemodialysis: independent dialysis and dependent dialysis. And what do I mean by that? Well, independent dialysis means that the person who has the kidney failure is doing the dialysis themselves. So they're doing home hemodialysis, or in some clinics, they have self-care dialysis units, but it's in the hospital or in the clinic, and the person just comes to that place, sets up their machine, puts the needles in, and does their hemodialysis there. So the benefits of independent hemodialysis then are, it's quite flexible, again, around your life, your job, your school. Independent hemodialysis can be done at night while you're sleeping, so that's called nocturnal hemodialysis, and generally is done 5 or 6 nights per week. It is probably the best form of dialysis for certain individuals. You get more dialysis if you're on nocturnal hemodialysis or if you're on hemodialysis at home. And therefore, if you have more dialysis, it's more gentle on your body. You often have more energy and you feel better. You're usually on fewer medications. there are fewer diet restrictions, but there's always a support team that can guide you and help you. So it's not that you're totally independent and don't have access to people that can answer questions for you. Some of the drawbacks, though, of independent hemodialysis is you need to have special access to electricity and plumbing. So there will need to be some renovations done for your home. And most dialysis programs in the country, in Canada, will pay for one-time renovations. One of the other drawbacks, though, is that your water bill and your electrical bill will be increased somewhat because of doing home hemodialysis. And in some provinces, again, you are given a subsidy to cover that increased cost of electricity and water. Again, you will need to have a storage space for the supplies for home hemodialysis. Of course, you have to have access to your blood system. So needles are generally required for the AVF or the AVG. And you have to have, and generally people are trained for a 6 to 8 week training period. So if you were at work, you would need to be taking time off work, or if you're at school, you would need to be taking time off of school. So that's sort of a brief benefit and drawback of independent hemodialysis done either at home or in the clinic. For dependent hemodialysis, therefore, you're going to the hospital unit, or you're going to a satellite unit, and either a nurse or a technician sets up the machine, and the nurse or the technician is the one that puts the needles in or accesses your catheter. So what are the benefits of this type of dialysis? Well, it's 3 or 4 times a week, generally 4 to 5 hours each treatment. So the rest of the days are free. You get to socialize with other patients. There's no equipment or supplies at your house. You don't need to go to the lab for blood work because blood work is done on the machine, and the medical staff manages your care. But some of the drawbacks are dialysis units are very busy and very full, and they have very little flexibility in your schedule. Definitely harder to travel because some units are so full that they won't take travelers. And usually more than 4 to 5 hours are spent in the hospital because you're waiting to get on the machine and then you're waiting to get off the machine. And if you have to travel to the hospital or clinic, you'll have parking and transportation costs. And of course, the travel time to the hospital or clinic 3 or 4 times per week also has to be taken into account. Certainly your diet is more restricted. And again, needles are required. Kidney transplant is considered the gold standard of treatment for people with kidney failure, for people that can have a kidney transplant, because not all people with kidney failure are suitable for kidney transplant. And that's because you have to be capable, your health has to be good enough for you to have such a significant surgery. So there are 3 types of donors of a kidney. There's a living related donor, so someone, your brother, sister, mother, father, child, or a living non-related donor, so your friend or your husband can donate a kidney to you, or there is deceased donor. And on the cartoon on your right-hand side, you'll see that the transplanted kidney is put into your lower abdomen. Most people's own kidneys are not taken out prior to a kidney transplant. The only time we have to remove a person's kidneys before a kidney transplant is if the kidneys are so big there's no room to put a kidney transplant in, or if the kidneys are infected, then we have to take out the kidneys prior to transplant. So for the recipient, the person who's getting the kidney transplant, there's an extensive workup to ensure that the person will be okay to have that surgery. And people have to demonstrate the ability to take medications and follow treatment plans before people will be transplanted. But again, some of the benefits of transplant are a better quality of life. Usually people are able to resume normal activities within 3 to 6 months after transplant. There's a lower risk of death from kidney failure, and there are fewer dietary restrictions. But some of the drawbacks are you have to take those anti-rejection medications for the rest of your life. Because we're giving you anti-rejection medications that decrease your immune system, you may experience more infections, and there is a higher risk of certain types of cancer in people who have kidney transplants. So with that, you can see that there are multiple options for treatment of kidney failure: peritoneal dialysis, hemodialysis, transplantation, conservative kidney management. And some people will go through various options, treatment options during their life. And I'm pleased to introduce to you Peggy, who's going to take you through her experience through some of these various modalities. Peggy, over to you.
Hey, thank you, Dr. Koppel. Hi, everyone. My experience with the different transplant modalities started 40 years ago. Not a lot of options were given to me in 1979 when I fell deathly ill at Thanksgiving. I required dialysis immediately. I started on in-center hemodialysis through an AV shunt in my ankle, later in my right wrist. Once I was stable and could leave hospital, it was decided that I would go do home hemodialysis, as I lived in a small town in New Brunswick, about 45 minutes to an hour drive away from the nearest dialysis unit. I had a fistula surgically created in my left wrist and eventually started training to do home hemodialysis. I remained on home hemodialysis in New Brunswick for about 8 months and then returned to university in Nova Scotia, doing home hemodialysis in an apartment while attending classes. My fistula clotted off in March 1980, and I returned to New Brunswick. I had a peritoneal catheter surgically placed in my abdomen and eventually learned how to do continuous ambulatory peritoneal dialysis, or CAPD. Unfortunately, peritoneal dialysis was not working properly for me, and I was placed on a priority list for a kidney transplant. I had also tried to have another fistula made for hemodialysis, but it didn't work. I received my kidney transplant in November 1981. This kidney worked extremely well for 10 years. I usually say 10 and a half years, but I knew my transplant was failing and I would eventually end up on dialysis again. As peritoneal dialysis had not been a good experience for me previously, I decided that I would try to have another fistula created and try in-center hemodialysis. I was working part-time at the hospital in clerical by then and married. I decided that I didn't want to bring a machine into our home at this time. I started in-center hemodialysis in June 1992 and was dialyzed via a fistula created in my left elbow. My name was placed back on the kidney transplant list again. This fistula wasn't working great and it eventually clotted off. I had another fistula created in my right elbow, which eventually clotted off as well. In December 1993, I decided to try peritoneal dialysis again. This time, peritoneal dialysis was a better experience, and I was doing well. In November 1994, I had my second kidney transplant, and this kidney lasted from 1994 to 1999. In 1999, again, I knew that I would have to choose what treatment modality of dialysis I would do. At this time, I had a 4-year-old son at home and wanted to be at home with him, so I chose to do peritoneal dialysis, home choice cycler. I did a couple of exchanges during the day, and then the machine did 4 exchanges for me throughout the night while I slept. I was able to get up with my son in the morning, tear apart the machine, set it up again for the night, and be free to do things with my son throughout the day. My name went back on the kidney transplant list for the 3rd time. In 2002, I got peritonitis and ended up in hospital for a month. I started in-center hemodialysis through a catheter in my jugular vein. I tried a couple of different peritoneal dialysis catheters to try to return to doing peritoneal dialysis, but nothing worked. It was decided that I could not return to doing peritoneal dialysis and I had to continue doing hemodialysis. I went into the dialysis unit 3 days a week for 4-hour treatment each time. I started early in the morning in order that I could be home by the time my son got home from school. My husband got him off to school in the mornings, and they would hang out together on Saturdays, usually coming to pick me up after my treatment. In 2010, the dialysis unit was trying to set up a self-care unit, and I decided that I wanted more control over my treatment. I volunteered to be one of the first to be trained on the machine for use by me in center. I would go into the dialysis unit, set up my machine, control everything about the machine while having my treatment, and then take myself off of the machine when treatment was complete. This worked very well. Then came the traveling back and forth to the hospital. The winter of 2014-15 had been a particularly hard winter weather-wise, and I had traveling back and forth to the hospital about 20 to 40 minutes both ways, depending on the traffic. In early spring of 2015, I asked if it would be possible for me to do home hemodialysis at home, and everyone agreed. I completed the rest of the training that needed to be done, and I went home with the machine set up in my home in April 2015. I am continuing to do my treatment at home 3 days a week for 3.5 hours of treatment, and continue on with my 40-year experience with dialysis treatment. Thank you. I'll now give this back to Dr. Koppel to continue with what to consider when making your decision.
Great, thank you, Peggy.
You're welcome.
Tracy, it doesn't seem to want to let me go to the next slide, so could you do the next slide, please? Thank you. So what are the things that you need to consider when making your decision? So some of the questions, as we talked about earlier in this talk, was you need to ask your healthcare team is, what is your prognosis? What is your life going to look like? How long would you have to live? How active a life do you lead? So, because that will make a big change in your life and determining which kind of dialysis you would like to think about. Are you worried about diet and food restrictions? Do you want to travel? Are you thinking about starting a family? Because certain types of dialysis are better for that than others. What is your home situation like? How independent do you want to be? Do you want to still go to work or to school? Do you have to take care of other people? So are you the primary caregiver for your spouse or for children? So that will determine what type of dialysis you would like to look at. Are you concerned about side effects of drugs and treatments? For instance, all the drugs and medications that you need to take when you have a kidney transplant. What would your quality of life be if you're on dialysis, or what will your quality of life be with conservative kidney management? How far do you live from a dialysis center? Because that makes a big, that's one of the big things in making your decision. And of course, there are many things in your life that may be important to you that are really not mentioned on this slide that are also important when you're making your decision about what dialysis modality or what treatment modality for your decreased kidney function is best for you and your family. Next slide, Tracy. So in the end, it's important to live well with chronic kidney disease. You need to learn all about it because really knowledge is power. You need to be your best advocate. Ask questions. Any question is important. Keep tabs on your tests. And I like to suggest to my patients that they buy a 3-ring binder and keep all of the papers that the healthcare team gives you, and ask for your test results, because you do have the right to have your own test results. Build a connection with your healthcare team, because they're going to be your best advocate as well. Family and friends are very important. So create and maintain that solid network, because they'll be there when you need help. Wherever possible, exercise and eat a healthy diet, because that makes you feel well as well. And work and school are good for you. Perhaps you can't work full-time or go to school full-time, but how about working half-time or working 2 days a week or only taking one class instead of taking 4 classes. And make plans for the future. Talk with your family and healthcare team about them. What do you want to have happen to you if you can no longer speak for yourself? And really, sometimes we get so focused on what's happening with our life and our treatments that we don't take time to enjoy a minute, enjoy an hour, or enjoy a day of your life. So I hope with that you have some information about the options for decreased kidney function. This is an overview, and everyone's underlying life and condition are different. And so it's very important that you discuss this with your healthcare team, with your nephrologist, and with your family about what you want to happen for you. So with that, I'm going to turn it back over to Tracy for the question period.
Thank you, Dr. Koppel and Peggy, for such an informative presentation today. As a reminder, you can still submit questions by typing your questions into the questions box of your attendee control panel. Our first question, Dr. Koppel, how long does a manual PD exchange process take?
Okay, that's a good question. So the usual manual exchange takes about 30 minutes. So you have to warm the bag because you don't want to put cold solution into your belly because that really hurts. You want to warm the bag. You have to attach it to your catheter. The fluid that's in your abdomen has to be drained out. And then the catheter, that tube is clamped, and then the clean solution is put into your belly. So usually if your catheter is working very well, it takes about 30 minutes for every exchange. So 30 minutes in the morning, 30 minutes at noon, 30 minutes at supper, and 30 minutes at bedtime. Most people actually watch television or play on their phone for longer than that in the daytime.
Thank you, doctor. Our next question, if I had my gallbladder out, can I still have a PD catheter?
Yes and no. So it depends upon how your gallbladder was removed. If your gallbladder was removed with a laparoscope, with those little cuts that you have in your belly, the chances that you will have scar tissue or adhesions in your belly are very low. And so a peritoneal catheter can be inserted quite easily, and the catheter should be functional. Sometimes in the past, when people had to have their gallbladder out, they had that really big, large cut on their abdomen. And depending upon if the gallbladder was very infected or very inflamed, sometimes there will be lots of scar tissue that develops. And so in that situation, maybe a peritoneal dialysis catheter can't go in. But the only way to find out is actually to try to put one in and see if it works, because sometimes you're actually pleasantly surprised.
Thank you. And Dr. Koppel, next question's for you. Can I have a transplant before going on dialysis?
Yes. You can have a transplant before you go on dialysis. So in that situation, you need to start talking about your treatment options when you're at stage 4. So that means that your kidney function is greater than 15%. Because if you're talking about what we call a preemptive transplant, so a transplant before dialysis is required, then your healthcare team has to make sure that you have done all the tests that ensures that you are healthy enough to have a transplant. And then if you have a living donor, that living donor needs to be worked up as well. And that living donor workup sometimes can take anywhere from 6 months to more than 1 year. So you have to be really thinking ahead about a preemptive transplant. So one of the questions that you should always have to your healthcare team is, am I a candidate for kidney transplant? And if so, what do I need to do? One of the hardest things, though, is to ask your family or friends to donate a kidney to you. And so that's why that conversation with your family and friends about what you're going through, that your doctor has told you that your kidney functions 20% and that you will eventually need to have a kidney transplant. That's the time to start talking about what would this look like if a person was going to donate a kidney to you. So absolutely, you can have a transplant before you need to start dialysis, but the workup is quite extensive. And so you need to start thinking about that sooner rather than later.
Thank you, Doctor. Just a reminder for those that have questions, you can just type your questions into the questions box of the attendee control panel. And Peggy, our next question is for you. What type of dialysis do you prefer and why?
There are pros and cons to all treatment modalities, including living with a kidney transplant. For myself, I believe that although I was not a wonderful experience in 1980, with advancements made, peritoneal dialysis using the home choice cycler machine allowed me to be home. It was a better diet, not as restrictive. I could travel easier, and I just felt more natural.
Can I jump in, Tracy?
Please do.
And Peggy?
Yeah.
So there was a study many years ago asking nephrologists, so kidney doctors, if they had kidney failure, what treatment modality would they want for themselves? And a majority of them chose peritoneal dialysis as their first modality. Mm-hmm. And then their second choice was home hemodialysis, and their third choice was in-center dialysis.
Yes, that would be probably the same for me.
Thank you. Our next question, Dr. Capel, can I get pregnant while on dialysis?
Yes, women can get pregnant on dialysis. It's not easy, and women have to have very good dialysis, and they must be well dialyzed for them to become pregnant. And if they become pregnant, then the amount of dialysis that they require per week increases dramatically. So most pregnant women will need at least 36 hours of hemodialysis a week in order for the baby to grow and mature and be delivered close to the due date. Women who are on peritoneal dialysis and become pregnant will have to switch to hemodialysis in order to get the amount of dialysis that is required for the baby to grow and be healthy.
Thank you. Our next question. Doctor, if I choose a form of dialysis, can I change it if I either don't like it or it doesn't fit into my lifestyle?
Yes, people always have the option of changing their dialysis modality. However, having said that, say you were on peritoneal dialysis and you were going to go to hemodialysis, but if you didn't have appropriate blood vessels for that fistula surgery or for the graft, or the blood vessels in your neck were narrowed, or you couldn't get a catheter in, then sometimes the other modality might not be there for you because of certain conditions of your own body. So it really depends. So that's why you would really need to discuss this with your healthcare team, with the kidney care team, about what you don't like about this certain type of dialysis, and can you move to a different kind of dialysis.
Thank you. Our next question, what are the effects or drawbacks for a kidney donor?
So the kidney donor has to have an extensive workup to ensure that their health is excellent to donate one of their kidneys to the recipient. So the kidney donor goes through an extensive workup, including blood tests, urine tests, scans, sometimes CT scans, sometimes even angiograms, where we have to put dye into blood vessels to ensure that everything is okay for that person to donate a kidney. So when a person has donated a kidney, then they're left with one kidney, and people can live absolutely normal lives with only one kidney. In fact, people can live absolutely normal lives with 2/3 of one kidney. So the only thing after donating a kidney, people need to be ensure that they have annual kidney blood tests done to make sure that their one kidney is functioning well. They need to make sure that their blood pressure is checked on a regular basis to make sure that they don't develop high blood pressure. And of course, as we all get older, we all have a risk of developing type 2 diabetes. So a person who has donated a kidney must ensure that they have annual examinations by their family physician so that all of these things can be checked to ensure that their remaining kidney functions well.
Thank you, Dr. Capel. We don't have any more questions for right now, so I would like at this time to thank both of our speakers, and I'd like to pass it over to Lydia Lauder from the Kidney Foundation of Canada for closing comments and to say a few words. Lydia?
Thank you very much, Tracy, and thank you, Dr. Capel and Peggy, for providing such an informative and educational webinar this evening. And I just also wanted to talk briefly a little bit about the Kidney Foundation of Canada, and it's committed to achieving excellent kidney health, optimal quality of life, and a cure for kidney disease. And how we do this is by funding and stimulating innovative research for better treatments and cures, provide education and support to prevent kidney disease in those at risk, and empower those with kidney disease to optimise their health status. We advocate for improved access to high quality healthcare and are committed to increasing public awareness and commitment to advancing kidney health and organ donation. Most people, when they're first diagnosed with kidney disease, a family doctor or nephrologist will provide lots of information about the different treatment options for kidney disease. But on top of that, the Kidney Foundation is also committed to providing education about kidneys and kidney disease to patients. For example, we distribute free of charge books and brochures to anybody who is finding themselves with chronic kidney disease, and our treatment manuals also look at things such as treatment options, diet, exercise, lifestyle, and they have been specifically developed for people with kidney disease. Even with the availability of resources and the information found at hospitals and through people's healthcare teams, many people can still find this information overwhelming when they're first diagnosed. For these individuals, it can be difficult to find the answers to all the questions and all the issues that they may be facing. So through our regional branch offices, the Kidney Foundation is able to help by offering advice and support on accessing services within the healthcare system, assisting people to access other community supports and resources as appropriate, and offering assistance in developing skills for self-advocacy. So we invite you to connect with us if you have any further questions, would like to speak to some people in your local area about kidney disease, and accessing further education materials and resources as needed. Thank you again to everybody.
And thank you, Lydia. And again, thank you for both of our speakers today. And thanks for everyone for attending today's webinar on treatment modalities for people with kidney disease. Once you leave today's webinar, you'll receive a survey on the presentation, and we'd appreciate it if you can complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view today's recording. And on behalf of the Kidney Foundation of Canada and our speakers, thanks for joining us today, and have a great rest of your day.